when I'm a little bit late, okay, please. Then maybe this one I will start first, as the 2, 3 first. Just like this, is there any ideas? Then first, do you see any abnormalities? Yeah, abnormalities here. You see little foci of contrast enhancement within the sulci, maybe also into the brain itself. Okay, at least a leptomeningitis, maybe rather patchy. Also a dural enhancement, you know, when it's continuous. It's not normal. Normally the dura may enhance, but usually it's a discontinuous enhancement. And then you may be affirmative that it's, well, it's a meningoencephalitis related to varicella. Hard to check, huh? It could be meningeal as well. Bacterial as well. Another one. You see, this is post-contrast, this is pre-contrast. You have many deep lesions. Then when you think deep, think of hematogenous spread, okay? And you have cortical, subcortical lesion. It can be, can be due to stroke. Here you have bilateral occipital lesion that could look like stroke. You have actually vasculitis, and you have also some air in the brain, okay? That was due to an anaerobic protein called Proteus mirabilis, which is usually involved in a urinary infection. Well, really hard to make the diagnosis on imaging only. And this one, is it pachy or leptomeningeal? Lepto, huh? We agree. There's a leptomeningeal reaction, quite diffuse, okay, convexity around the midbrain, and you see on FLAIR image this discrepancy between the dark signal of the ventricles and the very high signal of the subarachnoid space, okay? Well, using SWI, you don't see that much, and this is a leptomeningitis, but which one? Of which germ? It could be whatever, bacterial or viral or whatever. On the follow-up, there was even a focal lesion that was developed close to the chiasma, and actually it was a tuberculosis, okay? Then we have the pictures for the workshop, actually for the books, where the tuberculosis look like it should look, and in practice, tuberculosis may mimic a very common bacterial leptomeningitis. Okay. Then please. Oh, sorry. It was the same. Sorry, it was the same picture as before. Just remember, we had this. We've used this before. That of course it's not because you see a leptomeningeal or pachymeningeal enhancement that it's specific of infection. Okay, then let's go. This is a 55-year-old male having febrile headache, a cerebral syndrome.
There is a ring-enhancing lesion in the right posterior cerebellum on the post-contrast imaging and on the DW. Is that DW?
This is a FLAIR.
FLAIR. On the FLAIR, it's got quite a high signal intensity with edema around it, and the edema extends into the grey matter and the white matter. Okay,
then the content here is always two things. There's the capsule or the rim of the lesion, and the content, necrosis or whatever. What you see that on FLAIR image, the signal is not suppressed like water, then it's not pure water. Then diffusion is quite helpful.
it's got a high signal ring on the DWI and on the ADC map. It's got, well, kind of heterogeneous signal, and some of it seems a bit restricting.
Mm-hmm. Okay.
It's got potential intraventricular lesions as well, that in left lateral ventricle, right lateral ventricle, and also a cortical ring-enhancing lesion in the temporal lobe.
Okay, then will be simple. It looks like abscess, huh? It looks
several
like
abscesses.
And actually, it was some abscess related to stent. Okay, other one. We'll have our...
This the first is T1 without contrast media with, and on the diffusion and EDC there is a ring diffusion restriction, and for further lesion smaller in the right parietal occipital region. So it can also be an abscess.
Bacterial abscess, huh? Okay, and that's right. Okay, another case. What about that one? Do you want to keep going, or?
This time we have a big ring-enhancing lesion with a lot of vasogenic edema around it, very extensive edema. On perfusion, it doesn't seems hypovascularized.
Yeah. And what about spectroscopy?
There is a big. What is this?
Then you have to read. Here is about 2.4. Here is 1.9. Here is 1.3. Here is 0.9. You have no Na, no creatine, no choline. Huh? It's typical spectrum.
Is that bacterial abscess?
That's right. Okay, and actually there was at least 4 different germs into this abscess, and it was related to a tooth problem. Okay, so remember the signal on diffusion imaging is very suggestive. Then this could look like a glioma or metastasis, but diffusion make it less possible. Perfusion also, because you don't have any hypervascularization, and spectroscopy provides you different elements that suggest it's also or demonstrate that it's not a normal necrosis, it's real pus. Okay? You can keep on that one.
You see enhancement of the meninges, pachymeningeal enhancement.
Okay, pachymeningeal enhancement. Here.
Yeah. In the middle, there should be a hematoma.
I don't know. Is it an hematoma? That is a question.
No.
You would have a CT, you wouldn't raise so many questions. Okay, T2, it's not that dark. Okay, T1, it's not that bright, but you have
Restricted
a
diffusion.
DWI hyperintensity due to a restriction of diffusion. That's right. Oh, well, actually the signal on T1 and T2 is not really suggested, but it's we agree, a subdural collection. Okay, it's a subdural collection, and when you have hematoma, even on diffusion, you may have hyperintensity and decreased diffusion coefficient, but usually it's not that homogeneous. It's maybe on rather foci, and of course, it was an empyema. Another example, okay, then we will skip that one. Again, different context, but you see that the water suppression doesn't work, and even on the empyema, you have an increased signal on diffusion. Okay. The story of this patient was a woman, 69-year-old, with progressive cognitive disorder since 6 months, and there was some myoclonia, and the question was, is it a Creutzfeldt-Jakob disease? Then, do you have any element to suggest a Creutzfeldt-Jakob disease? We said it's usually hyperintensity on T2 and diffusion of the gray matter, whether cortical or subcortical. Then here, do you see any hyperintensity of the gray matter, whether superficial or deep? Well, maybe here it's stronger, but well, we don't see so many abnormalities. What's wrong? Sorry. Oops. I can't go back. Anyway, sorry. There was maybe a problem in version. Anyway, here, I guess a problem on the slideshow. Anyways, this is a different case. Sorry about this. A different case in a patient having this pontine involvement, cerebellar involvement, bilateral cerebellar involvement, also a midbrain involvement, diencephalon. Diffusion image didn't show any particular restriction. You see on post-contrast image, it was nothing to see, and the idea was to think of listeria. Then I hope I will think back. Okay, then let's go on this one. Okay, do you see anything?
Here you have higher intensities in the pons.
In the pons, midbrain,
Midbrain.
medulla, and on post-contrast you have a slight leptomeningeal enhancement, you see, on the anterior aspect of the pons. Then you have a leptomeningitis here, and an encephalitis of this part of the brain. So I told you, you have to think on at least 1 or 2 diagnoses. Lyme, it could be a good idea. And what else? Listeria, okay? Listeria is the thing you always have to keep in mind. But the fact is that in this case, it was a Lyme. Okay, then keep both in your mind. Okay, another example. Actually, it's also Lyme disease. I will hurry up a little bit. It's also Lyme disease, and it may mimic, you know, this very unspecific hyperintensity on T2 of the brain, you see here. And really, when you look at the different image, there's not so much to see, except on this little hyperintensity. It was a Lyme as well. The fact was that on this patient, there was only a very focal enhancement that was quite a bit suggestive of Lyme, of the cranial nerves. Here on the cochleovestibular nerve. Okay, this is a case we've seen already. it was herpes. I will have maybe another case. Okay, then please. It's a massive lesion. Usually they shouldn't come this way.
Hypointensity, it's huge area.
You were talking about hypointensity?
Hyperintensity.
Hyperintensity?
Yes.
Okay, in the temporal lobe. Okay, amygdala. Okay, hippocampus as well. All the outer part of the temporal lobe, but also the frontal basal area, the cingulum area.
Herpes encephalitis.
Yeah, it must be. I mean,
they're different.
It could be something else. It could be a different virus sometimes. Okay, but it has to be considered as a herpes until they demonstrate it's not. Okay, and he has to be treated as if it's an herpes, and actually it was. Okay, this was the case I showed you. Sorry, I'm just really here. Another case.
There is this hyper intensity in the colostrum. Yeah.
I don't touch anything. Can we go back? Well,
so this is this callosal hyperintensity, which was typical for this MERS.
Okay, here you have a hyperintensity of the corpus callosum.
Yeah.
On FLAIR, even on diffusion image. Okay, and sometimes you have additional lesion. Okay, here in the white matter. Then in a certain way, it's a kind of encephalitis. But what is very suggestive is this splenial lesion that are reversible, and actually 2 months later there was nothing to see anymore. And it was a lot of MERS syndrome. Okay, here.
Well, there is a.
You may ask for something else. If it's not enough,
for
we have additional image.
Well, there is a peripherally enhancing lesion with copious edema, with copious surrounding edema in the left parieto-occipital lesion. It is cortically, it's a cortical lesion, or corticomedullary maybe. And well, maybe diffusion-weighted images and also spectroscopy are needed.
You won't have much than this.
Yeah. So the main thing is that in T2 there is central hypointensity, like that dot sign within the lesion, and also in the associated CT scan there is a hyperdense area within that lesion, compatible mostly with a calcification mostly in the lesion, so neurocystic psychosis.
Good, especially from someone coming from Madagascar. And you see this little calcification, with surrounding calcification, the central calcification corresponding to the scolex of this form. Another case, but which is not so obvious. Actually, at the very at this phase, you see that you don't have any reaction, surrounding reaction around this little cyst. Okay, there's only a very subtle enhancement of this surrounding part of the cyst, but you don't see any calcification. What you have to think is it could be neurocirrhosis because of the origin of the patient, and have to look for it. Especially at the early phase, you don't have a clear reaction of the brain against this foreign or alien agent.
We see bilateral high-intensity signals, periventricular,
on which sequence?
in the basal ganglia. I think this is DWI. and it is, well, you have to think about, in terms of the clinical presentation of Creutzfeldt-Jakob disease.
That's right. We have to think on Creutzfeldt-Jakob. Of course, it's not specific. You may see this kind of lesion after anoxia, for instance. Usually it's not exactly here. It's usually bipalladal, but sometimes you have to keep in mind that it can be something else. But with such a presentation, it has to be suggested, and they will look for the protein 1433 in the CSF, and actually it's Creutzfeldt-Jakob disease.
In this case, we have cortical hyperintensities also in the diffusion imaging, which may also be caused by Creutzfeldt-Jacob's disease.
That's right. Okay, then now you see, remember, when you see a gray matter lesion that can be symmetrical or asymmetrical, that can be superficial or deep, think of on Creutzfeldt-Jakob disease. Okay, then remember clinical biological data. Of course, most of the time we do imaging to be able to rule out intracranial hypertension. And when you have difficult access to MR, I mean, the MR shouldn't postpone any kind of treatment. Think of all the 3Ds, post-contrast 3Ds and so on, to diagnose leptomeningitis or to try to be more sensitive to meningitis. And when it's mainly located to the basal brain, you may think of tuberculosis. Remember the rhomboencephalitis due to listeria or Lyme disease. When it's temporal, always think of HSV, herpes. And of course, when you have cysts, diffusion is very helpful to try to demonstrate it's a pyogenic abscess. When it's calcified, think of neurocirrhosis and gray matter, Creutzfeldt-Jakob disease. Okay? Any question? No? Then thank you for attention.